Welcome everyone to our Spine Deformity Cases Expert Insights webinar series. We have a great panel for our case discussions today. Our topic or focus for today is going to be young adults with idiopathic scoliosis. I'm going to start this off with a case. This is a case of a 28-year-old female who presented to me for evaluation of scoliosis. She is presenting now because she's having some pain over her lumbar prominence, which she rates as 5 to 6 over 10. She was initially diagnosed with scoliosis in junior high, recommended physical therapy and bracing. She's now quite active. She exercises regularly. She does have a family history of scoliosis. She's otherwise completely healthy, no other medical problems. We'll move on to her x-rays. Physical examination was normal except for the lumbar prominence. So here are her x-rays. I'll pause there for a second, see if anyone has any comments before I move on to we do have supine x-rays and an MRI scan after that as well.
Zeeshan, I think it's always important to kind of figure out why at age 28, again, they're coming in to see you. You mentioned that he's having a little bit more pain, but that's in these kind of young patients, kind of post teenage years, where they're kind of showing up because their parents are bringing them in, and someone noted a scoliosis. Why at this point in time is she presenting to you? You kind of detail that, but I really try and hone in on that in patients in their 20s and 30s, because there's got to be some trigger that brings them in. Everyone in their 20s and 30s are busy, right? Busy lives, and so that's, I think, critical to understand why they're seeking advice from a physician/surgeon.
Yeah, pain was one, progression of pain over the lumbar prominence, and the other thing was just progression of deformity that she has noticed herself. And as she had told me initially, wasn't really compliant with treatment of the scoliosis itself, and now as she has become a bit older, she's concerned about it. She has noticed the progression, and she wants to essentially treat the scoliosis itself now. But now she's interested in following up. She's married, doesn't have kids yet, so she wants to basically get this treated. Pain is part of it.
The other thing I'll mention, Zeeshan, is that often physical appearance is definitely part of it. I can see she's very thin. So, as you know, everyone kind of sees themselves in the mirror, and especially when they're thin, they kind of notice their deformity. So that's often a big driver.
Yeah,
I was going to ask about her body habitus and the
Yes.
fact that she complains of pain over that lumbar prominence. She's got quite a bit of rotation, and she is quite thin, as Dr. Linke just pointed out.
Yeah, she's thin. She works out, exercises regularly. She's quite thin, and that's why she kind of notices that, obviously, as well. All right, great. In the interest of time, we'll move on to the next slide, which is her supine x-rays. So the supine one, there's a little bit of flexibility to the curves, and we wanted to point out the lumbosacral curve as well, which is about 13 degrees in her. And we'll go on to the MRI scan here to show, essentially looking at, she didn't really have any stenosis, not much in terms of disc degeneration. You can see a little bit of asymmetric degeneration at the L4, L5 disc, but overall, relatively okay looking MRI scan. So I'll go back to the x-rays here, assuming we obviously talked about surgical treatment for her, for the scoliosis itself. Any suggestions on level selection or type of approach, or what we should do for
her? I think that the lumbar is going to be the most problematic over time. And, if she waits and waits, sometimes the lumbosacral junction really becomes a problem. And then you end up needing a longer fusion to the pelvis. So she already has pain. And I think it's really important to differentiate if the pain is coming from the curve itself, the apex of the curve, or the lumbosacral junction. Because, some of these people hurt their low back, and then they have a disc herniation or spondylolysis down below. And then you have to be really careful because you end up with a long fusion down to the pelvis. That's the problem that, you want to prevent. So
Yes.
looking at this right now without any lumbosacral pain, just pain at the apex of the curve, then you fuse the curve and don't go down to the pelvis, because that's what you want to prevent, the asymmetric facet stress and distress at 4551.
So where would her pain is at the lumbar, the apex of the lumbar spine.
I probably will do the thoracic and lumbar both, because I don't like to leave the curve above and worry about it.
This really is a bit tricky because obviously the thoracic curve is real, and it's not just a compensatory curve anymore. Right shoulder looks a little high clinically, so if you do a selective lumbar fusion, that right shoulder is going to be driven higher, but at least temporarily. So you got to warn the patient about that. 3 is rotated. It's got a bit of rotatory subluxation, 3 on 4. So you're probably gonna have a little bit of disc wedging of 3, 4 if you stop at 3.
And we had all the discussion with the patients regarding the different options. But I did talk about selective lumbar versus thoracic and lumbar, or doing nothing and watching closely.
Mike, let me check. Mike, obviously you're in a children's place now only, but anyone in San Diego do a tether on this?
No. Even even Peter, who's I think one of the foremost thought leaders in tether, it happens less than once a month here.
Perfect. So I actually decided on upper thoracic to L4 in her because I was concerned about the disc wedging and residual tilting towards the side. We'll show you what be there. So this is what happened. This is early post-op, kind of first post-op. She looks good in the sagittal, but on the coronal, as we can see, she's tilting towards the left side. Even though I've gone to L4. And so the question is now what? This is the first post-op. And she's noticing that. She's noticing that, hey, why am I tilted towards the side?
Yeah, well, just even take a step back and talk about surgical options.
Just curious on the supine intraop x-ray, Zeeshan, was the left hemipelvis elevated? Is this a fractional lumbosacral issue, or is this just a post-op muscle fatigue issue, or a combination of both, maybe?
Yeah, post-op issue, intra-op, she looked quite well balanced. The hemipelvis was not adequate on that side. Yeah, so it's basically a post-op issue. She's standing up.
I would sit tight. She'll get better.
Yeah. So I talked to her about putting in a temporary iliac fixation to balance her out, and then removing it in a few months. And we were actually scheduling that. But in the meantime, I had her start physical therapy to see how she does. This is her. So then she comes back at 2 months, a lot better compared to the initial one. And then here's her at 6 months, totally balanced. So I ended up obviously not doing anything else. So with physical therapy, with time, she put in a lot of work as well. She was very compliant with the physical therapy. And here's her sequence of going from pre-op to initial post-op that really kind of made me concerned me to the sequence over time.
I presume she was very satisfied with the outcome.
Yeah, she's happy.
Looks great.
A little bit different this time. This is a 31-year-old female who presents with a chronic low back pain and left leg pain. She was also diagnosed at age 9 to 10, treated with a brace. She was compliant. She had some back pain in high school, which led to her stopping swimming and some other activities, but she still tried to remain quite active. But over the years, because of the pain in her lower back, she had to cut down her exercising and other activities. She comes to me now mainly because of lower back pain, not because of the concern for progression of her scoliosis, but just a lot of lower back pain. She's done PT. She's from out of state. She has tried epidural injections. That's her pain profile. So she reports 7 out of 10 pain, most of it 75% lower back, and about 25% in her left leg. And she has already, by this time, she has had 2 prior discectomies, one at L4-5 and one at L5-S1. And the last one was about 2 years ago. And we'll go on to her x-rays. This is what she looks like. Comments, Mike?
Well, I was hoping you were going to show one like this, but I didn't want the lumbar curve to be so big. But I think for me, it would be nice to find out what this lumbar curve was 5 years ago, and see how much this lumbar curve is progressing. I find it reassuring that the lumbar curve, not the fractional curve, but the lumbar curve still doesn't have rotatory subluxation. Maybe 3-4 is starting to slip off a little bit to the side there, but 4-5 looks terrible as far as I can see, and I can't really even make out 5-1. It's hard to tell on the lateral. And the thoracic curve is nothing to really be concerned about. She has a very subtle thoracolumbar kyphosis, but again, unless she's complaining of pain there, I'm probably going to try to ignore that, and drill down what her pain generator is, and really hope that it's 4-5-5-1 so that I can do the forward of the sacrum that Dr. Lenke was talking about in the last case.
Dr. Lenke, any comments? So pain is really lower back pain, and she's getting radicular pain going into the left leg.
Yeah, I mean, she's had prior discectomies there, so most likely she's just kind of wearing out, right? 4-5-5-1.
Yeah.
But obviously advanced imaging is necessary to confirm that.
All right, so here's an MRI scan. And so we can see obviously end plate changes on the left side at L4-5. Pain is all on the left side, not much on the right in terms of the end plate changes. And you can see degeneration at 4-5-5-1. The 3-4 looks pretty reasonable, actually, above that in terms of the disc. And then you can obviously see prior laminectomy and scar tissue, evidence of her prior surgeries, and some stenosis here in the lateral recess on the left side, some on the right as well, but a bit more on the right, on the left side. And here I'll go back to the X-rays now, unless you guys want to look at the MRI scan again. Thoughts on the treatment? So she's had injections, she's had PT, she's had 2 prior discectomies. She's also, you know, she's thin. She used to be quite active, but she's basically stopped most of her activities because of this pain now. She's had different opinions in terms of not doing anything, you're too young to do anything, versus treating the full scoliosis, going down to the pelvis. So a few different opinions that she's had. She's basically presenting because she was given no hope that this is it. You kind of just got to deal with it. And so your thoughts on, should we do anything at all? Just let her deal with it and do something later on when she's much older, or act right now?
Yeah, a CT scan.
I would.
How much bone they took out for the discectomy, and just see what things look like at 3. And did they touch 3-4 at all? 3-4 is pristine, I assume.
3-4 was pristine. They didn't touch 3-4. Let's see. Maybe the MRI scan shows a little bit.
Looks like the joints are pretty beat up, even on at least 4-5, right?
Yeah, yeah. And on the 5-1, you can see they did a pretty wide bilateral laminectomy, full laminectomy.
Yeah, right.
At 5-1, yeah.
And this is where I like to kind of see what the joints look like at 3-4, because sometimes, you know, that makes you feel better. 3-4.
This patient is too young for us to just say, oh, just deal with it. There's nothing I can do here. That's really, I mean, honestly, when I'm 75, I probably think 75 is too young to get that prescription also. But this topic is young adult idiopathic scoliosis, and I don't think that that's a very helpful or thoughtful response. I think trying to drill down the pain generator, I think post-laminectomy syndrome is a real thing. I think this is post-laminectomy, post-discectomy. Those discs look terrible. I know as academics, right, that we say like, oh, you don't operate on axial back pain, but I think you throw out the baby with the bathwater if you just start saying, I don't operate on axial back pain. For me, again, like it just goes back to, I would, and I think the easier analogy for me is discectomy versus like T-lift patients, where I say, like, let's just try decompression. I'm not burning the bridge. If we go infuse it and you don't need a fusion, the bridge is like napalmed. It's totally gone. For her, I think an L4 to the sacrum is sort of the most conservative option that may offer her relief, that I think has the most, in my opinion, the most favorable natural history. Is kind of how I'm thinking about this for this young woman now, right? Is that I think if you give this young woman a T10 to the pelvis, if you do upper thoracic to the sacrum, not only are you taking away all sorts of activities from her that she will never do and employments that she can never have, but I think that her second surgery will be up into her neck at a young age, which sounds like not a great option. If I could do an L4 to the sacrum, give her even 10 or 15 years before that lumbar curve gets fixed. I
was fairly confident based on her symptoms and exam. Her pain was coming. She had a lot of L5 radicular symptoms. And just based on the imaging as well, with seeing the end plate changes, degeneration more on the left side, I was very confident it was from the L4 to S1. So, and she did have partial response, but short-lived from the epidural.
How about fixing to the ilium, Zeeshan? If you're going to do an L4 to S1, are you going to fix her to the ilium, or are you going to just do L4 to S1?
Yeah, great question. Young patients, good bone, I'm going to go to the sacrum. And especially a young female, who still is hoping to get pregnant. I will go to the sacrum, but I won't go to the ilium. I'm going to spare the ilium. And I'm fairly confident with good bone. I mean, she doesn't have she doesn't have a lot of instability. So I would go to the sacrum, not go to the ilium. In her older patients, totally different. Older patients routinely, even L4 to S1, even sometimes L5 S1, for someone with really bad bone, I put iliac screws in to stabilize that. But younger patients like her without, if a high-grade spondy, that's different. But in her case, she's not unstable. It's basically a two-level degenerative problem with back pain and radiculopathy. And so for those patients, younger patients, I try not to go to the ilium. Again, like I do think there is value in not putting those iliac screws in patients who are planning on still giving birth to avoid locking that pelvis in.
I would probably supplement with S2 Ayler screws. I know they're not great purchase, but sometimes you get lucky and they're triangulated up and out, as you know, so they're biomechanically better. But I agree, I would not go into ilium, but I wouldn't hesitate to throw in bilateral S2 Ayler screws additionally if my S1 screws weren't rock solid.
Yeah.
If you can get the alignment. Sometimes the joints are like these joints look a little nasty here and a little arthritic and spondylotic, and the one on the right there is encompassing the inferior facet of the level above. You can put in whatever degree lordotic implant you want, but you're not going to get that out of it. And then you need to either be fancy with the tubes or just do it open and realize that at 1 year, the outcomes are no different anyway. And it's all about getting a good surgery.
Dr. Lenke, you obviously have a bias towards posterior approaches. Your comments on A-lift versus T-lift posterior approaches?
Yeah, I think whatever you're best at. I mean, again, as Mike mentioned, young female like this, childbearing age, is certainly A-lift is very reasonable. Muscle looks pretty beat up already posteriorly, so you're doing a fusion. So
Yeah.
I personally like to, see the nerves decompress. If she's had radicular pain, I mean, I really like this. Especially, and she's had surgery, I like to really see the nerve, decompress it thoroughly, and not just depend on indirect decompression. But obviously, that'll work, 99% of the time. But I want it to work 100% of the time, so I'm going to decompress it formally and see the root and make sure it's free. And but that's maybe an advantage of an open posterior. But and again, also, as when they're denervated already, their pain is much less in the second procedure. So she's already had open posterior surgery. So.
So I'll move on to what I did. So I ended up just fusing 4-to-1. I did T-lift at both levels. Left her on purpose with a bit of a tilt just to not throw the curve over too much. Here we go. Where is it? Yeah, she actually did really well. She's, I think, about 2 years or so out from surgery now. Pain is gone. She's back to exercising, going for her workout. She's back to work. And obviously she knows that she has that lumbar curve above it, which may need to be treated at some point as that progresses. But for now, at least this is one of those patients where she was just given no hope that you're too young to have a fusion, just kind of deal with it and that's it, and stop doing activities. She's back to doing everything that she wanted.
Guys,
and you find I intentionally left it a little bit tilted, concerned that I don't want to correct too much. Great. Well, thank you very much, everyone. And thank you, everyone, for joining.